Good afternoon, everyone, and welcome to CurePSP's Ask the Doctor session number 9. Thanks to everyone who is tuning in today via YouTube and Facebook Live. We hope that you're all staying safe, healthy, and happy New Year. Well, I guess that we're about a month past that, but Happy New Year anyway. My name is Joanna Teters, and I am the Community Outreach and Resource Manager with CurePSP, and I will be the moderator of today's Ask the Doctor webinar. As many of you know, we've been hosting Ask the Doctor webinars for close to a year now with many neurologists in the PSP, MSA, and CBD field. But today we are so pleased to have physical therapist Dr. Bobby Hand here today to talk with us about the benefits of physical therapy for patients with PSP, CBD, and related neurodegenerative diseases. Many of you have submitted important questions about this topic. So after Dr. Hand's presentation, we will get to the Q&A portion of today's webinar. Please note that this is going to be a recorded webinar, and the recording will be made available on our website in the next few days, and a link will be provided in a follow-up email. A quick overview for the platforms we're using today. Please type your questions into the chat box or comment section of the platform you're using, but please use the chat box to interact with each other and ask questions and comments, but please do not reveal personal medical information as these platforms are not HIPAA compliant. And the questions that Dr. Hand will answer at the end of the webinar today, at his presentation today, were submitted prior to this event. However, if time allows, we may take a few questions that were asked live. Thank you for your interaction on these platforms as well. Dr. Bobby Hand was invited to join the CurePSP Board of Directors in 2020, and he continues to work closely with the Patient and Carepartner Advocacy Committee. Bobby serves as the Movement Disorders Program Coordinator at Virginia Commonwealth University Health Center in Richmond, Virginia. Prior to this role, he served as the clinical leader of the Parkinson's program at Sheltering Arms Rehabilitation. He is a board-certified clinical specialist in neurologic physical therapy and is also certified in LSVT BIG and Power Moves. He serves as a mentor in the VCU-Sheltering Arms Physical Therapy Neurologic Residency and is actively engaged with patient advocacy and education groups such as CurePSP and Power Over Parkinson's. He received his bachelor's degree in biology at York College of Pennsylvania and his doctorate of physical therapy from the University of the Sciences in Philadelphia. His clinical focus is on the development of groundbreaking disease-specific exercises and interventions for patients living with Parkinsonisms and other prime-of-life neurodegenerative diseases. And it is my privilege and honor to present Dr. Hand today to today's program and to all of you, and to work closely with Bobby in many different initiatives and programs here at CurePSP. So thank you so much for being with us, Dr. Hand, and looking forward to hearing your presentation today.
Great, thank you, Joanna. I'm excited to be here, and thank you for having me. This is my first public speaking event, and who knows how long, so forgive me if I fumble around a little bit, but it's an honor to be here and talk about something about which I'm so passionate, and that's physical therapy for patients living with PSP, CBD, and similar prime-of-life conditions.
Absolutely. We're so pleased to have you here. So you can go ahead and share your PowerPoint and we'll get started.
Great. All right. And Joanna, is it sharing currently?
Looks good to me.
Okay, here we go. All right, everyone. So thank you again. And I'd like to just provide a little insight as to what we'll be discussing before moving on with the PowerPoint. As Joanna mentioned, we're not necessarily discussing individual medical histories or patient-specific concerns with their therapies or with their mobility, but I can answer some general questions. And my goal here is to provide some insight as to how exercise might be underutilized in this population, just because of the many complexities associated with these diagnoses. So I'm going to provide a brief overview of physical therapy as a profession, maybe some specific exercises that are applicable in these different diagnoses, and a few points to consider from both the patient and provider perspective when ultimately we're all trying to come up with a cohesive and collaborative plan for the benefit of the patient. So an overview of physical therapy. This first bullet point is how our professional organization describes our role. So physical therapists are movement experts who improve quality of life through prescribed exercise, hands-on care, and patient education. And I think it's especially worth noting through many of the avenues explored through CurePSP, the quality of life it's a really challenging piece to document and measure when we're looking with insurances and providers and billing and all of the hubbub that goes on behind the scenes in regard to your medical care. But that's the most important piece, because ultimately we want to improve the quality of life of the person living with the condition and their support system or their care partner network. So we're treating a patient and their family as it pertains to quality of life. Now, that quality of life is often achieved in respect to physical therapy through improving independence with mobility, helping people achieve fitness goals, and leading active lives. Now, we practice in a wide range of settings, and I'll discuss this later thanks to a pre-submitted question. But just to clarify, physical therapists are present in most healthcare settings, ranging from hospitals to outpatient clinics, which is where I currently find myself, people's homes, which I've done in the past as well, some home health therapy. And then there are schools, sport and fitness facilities. Sometimes there are physical therapists in a workplace and also in nursing homes. And the role of the therapist is very different in each of those settings, just as the role of the therapist is very different on a patient-by-patient basis, and also as a patient changes over time. Now, these three bolded words are some of the key ideas behind our intervention selection in physical therapy. This idea of preventing, restoring, or compensating. So in very general terms, prevention would mean that we are preventing an impairment or decline from happening. So for example, you might not have issues with your balance or falls currently, but we know that practicing certain high-level activities might help you develop reflexes and strengths, etc., that would prevent falls in the future. So we can think of it as being proactive. Now, restore is the idea of recovering lost function. So oftentimes when I treat patients diagnosed with PSP, CBD, and other prime of life diseases, the ability to walk has been affected. And that's not to say that it cannot be recovered in some patients. This can be a restorative component in a short term. So if you, let's say, were quarantining for 2 weeks, and then you notice, well, after quarantining and not being as active, I had a very hard time standing up and walking. We can recover that function because it's a temporary loss and we restore back to baseline. But this can also occur, and we'll discuss this later, some patients who have been struggling with impairments and limitations for months or years, and then they receive the right dosing, the right therapies, and they can improve and recover function. It's not always a matter of maintaining the status quo. But that third bullet point is especially important today, the idea of compensation. So providing new strategies, or what you might call workarounds, to maintain a quality of life. So the example I've listed is teaching someone to use a walker to safely maintain physical independence. If we're discussing walking function in particular, restoration might look like walking without a device as you did prior to a diagnosis or many years ago. But if we can compensate and give you a way to still do what you want to do and participate in the things that give you meaning, it's a really great compensation. So we need to find a balance between trying to fix a problem, to find a good workaround, and then ultimately to be preventing any further complications or decline. So I like to share this in every single presentation I give to patients, care partners, and students of all sorts. This is adopted from an article by a very well-known neurologic physical therapist, Dr. Dalbello Haas. The idea that regardless of a diagnosis, we can kind of stage people based on how that diagnosis is impacting their day-to-day living. This can be across kind of the general disease and how it's affecting you globally, but you might have different stages on different aspects of your day-to-day living. So for example, early stage, few impairments and no or minimal limitations and no real disability, you might be able to walk without any physical issue and be early stage, but you might be a middle or later stage when it comes to examining your cognition or your ability to remember things. Now, kind of taking a step back here, in early stage, a general treatment concept would be it's early, so let's prevent things from worsening. So our number one focus should be on making things function at this level as long as possible. There might be some impairments as noted, so we want to restore those and get the person back to 100% or as close to that as possible. And you'll see in the lower row, there's a plus and minus for compensate. And this is where it really takes an expert clinician to decide, you know, I'm not seeing an issue now, but knowing what we know about this disease or this diagnosis, it might not be a bad idea to teach somebody how to use a device or to use a strategy now when they're less impaired, to really plant it in there, to teach them a new skill so that when they potentially worsen or have more difficulties with the activity, they've already learned this really useful workaround. So that's something that we're always considering too. As someone progresses more toward this middle stage description, we're going to start to see an increased number and severity of impairments. So this is often where people find themselves seeking out help from a neurologist or seeking out help from a rehabilitation team because of falls or because it's really starting to impact their day-to-day, that, you know, falls are happening, injuries might be occurring, or you may need a little bit more assistance from loved ones and care partners, and that's led to some disability. So in this middle stage, we want to compensate because we don't want you to, so to speak, worsen or decline further, you know, to function at a maximum capacity. And we want to prevent things from worsening. So keeping you at this level is our priority, but that plus or minus restore is also there too. If we can keep you here and possibly improve your abilities, that's what we should be targeting. And that takes really intensive therapies that we'll be discussing shortly. Now, later stage, I think this speaks to some of the questions that were pre-submitted. Folks who have many impairments and limitations resulting in widespread disability. This might be the individual who requires a power wheelchair and 24/7 assistance from a care partner or skilled aid. And these folks, we want to give them the best possible workarounds to interact with their environment and maintain a quality of living. And we want to prevent further complications that might arise from immobility or, you know, further decline in functional status. Now, there is no plus or minus restore listed on this slide, but that does not mean it is off the table altogether. At this stage, we can see some restoration of function if we try new things and new avenues. As new exercises and therapies come out, there's a chance that we can restore function even in these late stage individuals. And I'll be speaking and showing some video about that later. But I just want you to keep this in mind, that your therapy is individualized and tailored to where you are living with your condition at this moment and planning ahead for what we anticipate to come. So that being said, the role of the PT will change with the patient. And I like to describe it as new challenges lead to new solutions, not new challenges lead to new problems. Because with every change the patient experiences, that's an opportunity for us to come together as a team with the patient and with their care partner and find a way to maintain or improve their quality of living. That being said, medical events and other life circumstances may quickly arise and kind of change the need for PT or even the setting. So an example could be you're living at home and doing quite well, but You experience a fall with a major injury that leads to a hospitalization, or a urinary tract infection, which is fairly common in this patient population. It might be a brief setback. You work with a new skilled therapy team in that new setting, let's say in the hospital, in the step-down unit, in the outpatient clinic, and then kind of get back to where you were, or we're reassessing throughout that continuum to see where does this patient need the services most at this moment, this point in time. And there are different therapists working in those settings. Just to clarify, myself, I work exclusively in an outpatient neurologic setting. So I would not be your therapist if you were to end up in the hospital. However, that therapist in the hospital might not be as familiar with your diagnosis. And that's where it's so helpful to have documents prepared. And when you've built your healthcare team, keep that information on you at all times, because I will regularly communicate with therapy providers in the home or in the nursing facility for patients whom I've treated in the past. But that's enough about our role. How do you feel about physical therapy? So in 2020, CurePSP led an initiative surveying care partners and patients living with PSP, CBD, MSA, and other similar diseases to determine what was the cause of your interruption or discontinuation of outpatient-specific physical therapy, because that is typically where these folks are going to spend most of their time. If we can keep you living at home with or without assistance, the hope is that you are mobile and able to attend an outpatient therapy site. These are the patients that I keep in what might be called maintenance care long-term. However, that is not the widespread case if we look across the healthcare network. So some of you responded in great support of therapy services, but we saw far too many responses like these, and I'd like to read them, though you have this in front of your screen. The PT clinic could no longer reasonably say that therapy was resulting in improvement. They told us Medicare would only pay if treatment is expected to result in improvement of functional goals. My mom's progressive decline had made meeting PT goals unlikely. The next point, outpatient physical therapy was very beneficial for my sweetheart, but more so for training me on how to help him better and understand what was happening in his brain that affected his body. It was easier to be patient with him when I knew why he was or wasn't doing what he did. And the third and final quote that I've included here, as CBD is progressive, all physical therapy, speech therapy, and occupational therapy services seem to be so temporary. The therapists all seem to treat my husband as a reluctant patient. Perhaps their own lack of knowledge about the Parkinson's plus diseases was showing through. My husband now is either bedbound or wheelchaired with fingers that cannot manipulate the smallest of tasks. I feel that physical therapy, occupational therapy, and speech therapy were just futile practices to make the patient and caregiver feel that they were doing something to stem the tide of the disease. Now, I've selected these three responses in particular because I think they touch on three of the main points when we are trying to lobby for skilled services in these patients. And we'll talk about that kind of point by point here. So that first response really indicates the need for global education and insurance support. The person was told that without improvement, Medicare wouldn't pay for services. And that's a misinterpretation of an approved Center for Medicare Services document from 2014. So we know that there is support there even if improvement is not occurring, because our services can prevent major medical episodes, potentially improve longevity, and overall improve quality of life. And those things are invaluable. Patients need accessibility to services. So that second response, they found therapy to be very helpful for both the patient and themselves as a care partner. But that third one, That's, I think, where we can have the most impact right here and right now. Patients need clinical specialists for expert care. You have your primary care physician, but then you have an expert neurologist, a movement disorders trained neurologist providing your care specific to your PSP. The same is said about rehabilitation professionals in speech, occupational, and physical therapy services. So a good entry point for finding these specialists would be locating your nearest CurePSP center of care, or even just reaching out to that center and asking if they have any preferred referral sources. So I myself love to take on as many patients as I can, but it might not be realistic if you live 2 or 3 hours away to see me once a week or twice a week. But through my network and the networking that we do as professionals, maybe I found someone, in your local region who at least understands or is open to collaborating about your care. And that's who I would recommend, but you might not find them on your own. So that's a benefit of using this center of care network. Now, moving forward about this expert care, there are some hurdles that we have to get through first. So I've included a long excerpt from a recent systematic review. So when we're looking at evidence or from a research perspective, that's a pretty substantial piece, a systematic review. So somebody went through and looked at a number of different articles or research reports related to PSP specifically, and overall, they found that there's limited evidence in early PSP to be participating in physical therapy. So there are some gains noted and a few examples there, but the overarching theme is that there's just not enough data to support and say physical therapy helps. When all of us who have been involved in the care of someone living with PSP, CBD, MSA, and more, we know the immediate impact we have on that person's quality of life and a measurable impact through different outcome measures or subjective questionnaires. But here's the problem. If we're basing everything moving forward on evidence-based research, there's not enough evidence at this point in time for us to say, here's the perfect or closest to perfect physical therapy routine in frequency, intensity, type. We just don't have that yet. And that's where I see CurePSP moving forward and trying to answer that question, because we know there are so many valuable means of helping these patients. We just need to get out there and do the legwork, write it up and prove it and share these stories. And eventually this is going to change. And I hope to be a part of that. However, a reason for some of this difficulty, it's hard to recruit patients with these diagnoses to participate in research trials or to stay in physical therapy for long periods. Medical events arise, or it's quite burdensome to drive daily or twice a week for 30 minutes or an hour to go to a center to receive this type of care. So we struggle in recruiting patients to stay within a program consistently. This second point, thinking inside the box with typical exercise recommendations. I think it seems sort of silly that these diseases and diagnoses were referred to as atypical Parkinsonism, yet we're trying to treat them with typical Parkinson's disease exercises. Now, I think there's some great Parkinson's disease specific exercises that are cutting edge and breaking through to help those patients that might be applicable to these PSP, CBD, MSA, etc. patients. But general strength training, general balance training, of course there's limited evidence because it's not the most effective means for anybody, even a healthy person. We need to break the mold of what is normal and push our boundaries a bit more. And that's my personal passion. And then the third point, again, no two patients are the same, even with the exact same diagnosis. And there's so much overlap in these different tau-based disorders such as PSP and CBD, or the synucleinopathies like multiple systems atrophy and Parkinson's disease. I mean, we're looking at different pathologies and every person is unique. So it can be a little corny, but everyone is a snowflake. And we have to treat everybody with that respect when assessing them, developing their plan, and determining how we're going to move forward to best serve them. So I'd like to move forward and kind of provide my personal recommendations after doing various reviews of literature, but also talk a little bit about some things that I personally do with my patient population to try and give them the best chance out of a life that they would describe as being very full and having much meaning to them. So it is a combination of some evidence-based research, a very brief review. Please, this is not a dissertation of any sort. We're just going to move forward and I'll touch on some points, but if you have any questions about specific literature, please reach out. I'd be more than happy to share it. But I like to put a personal spin on it too. There were a number of questions about ocular motor and visual exercises for people specifically with PSP. So how do we treat someone's eyes? Well, the eyes are controlled by muscles just like muscles control walking or muscles control speaking and swallowing. We know that those muscles respond to training. This idea, if you don't use it, you lose it. So if we take a little step back here and look at the different types of eye movement, there are what's called saccades, which would be the rapid movements, kind of bouncing your eyes back and forth from one thing to the next. Smooth pursuits, where your eyes are moving slower but keeping something in focus as it moves. Vergence, which is converging or diverging. So the idea of tracking something as it gets either closer to you and you might go cross-eyed, or it goes further away and your eyes need to keep the object in focus, but they're both moving in opposite directions. And then vestibulo-ocular movements will stabilize the eyes while the head moves. Now, specifically, patients with PSP are challenged by fixation, keeping an object in focus, and these saccadic movements, especially given the name of the diagnosis, the supranuclear palsy. We see the struggle to perform vertical saccades, especially looking downward. If we know that's a problem, as soon as someone is diagnosed with this condition, we need to prescribe an eye movement exercise program, because there is evidence to support that eye training with balance exercises can improve gaze control and reduce falls. There was a paper that came out a number of years ago that actually went back and chronicled the reasons for different falls. And what they found was that falls are more related to slow movement or difficulty initiating movement combined with ocular motor or eye function than they were with cognition. And that's something that a typical provider who does not work with these patients might not understand, because we see such cognitive change in various diagnoses pretty quickly. So we assume, well, Mr. or Mrs. Smith was impulsive and they got up without safety in their mind. They stood up quickly to reach for something and they fell. That can occur, but more of these falls were due to that difficulty in both moving the body, moving the eyes, and then that relationship between eye and body movement. So I cannot understate it enough that these exercises need to be prescribed early, and we need to have some regularity with completing the exercises. So looking at different ways to train the eyes, it can be something simple, like a number board or various iPad applications. Oftentimes they're developed for patients with concussion or pediatric patients. They're much more visually stimulating and engaging than if I tell you to stare at an eye exam chart and read that over and over. So we can do these sort of hide and seek or word finding, word searching type puzzles. You can make that a cognitive challenge in itself, of course. And we can do simple things like sitting in front of a mirror and laying out a different color in each corner and trying to quickly cycle our eyes from color to color, just training those muscles that move the eyes over and over and over so that they are as strong as possible, that mind-body connection is retained as long as possible. These are challenging exercises to prescribe, though, because they can get quite repetitive. So we need to make it fun. Excuse me. So I would say prizes and rewards are great motivators when working with your loved one. And then that next point, make it cooperative. So one of my favorite things when I've been fortunate enough to work with patients with PSP or CBD, when they have a great support system and they might live with one of their adult children and that child has kids. So the grandparent is in the home with grandchildren. Try to get the children involved playing these I Spy type games, looking around the room for various colors or watching the television and trying to quickly identify things as they're moving. It's nice to have someone there with the patient doing the exercises to make sure that they are in fact doing them. Because you can say, did you look and see that? If they're by themselves, they might not be kind of checking in on themselves, but we can always be there to provide cues to stay on task and sort of keep pushing through with the eye movements. We also want to make these exercises challenging. So if you're physically able to stand, and cognitively, if it's appropriate, we can find letters to make words or remember number or letter sequences, etc. But overall, it's most important to make it a habit. So these exercises are not physically exhaustive, so they should be done every day, multiple times a day. Now, I'm not going to speak as much on this point in this talk, but strength and endurance training is, I think, the most interesting when it comes to this patient population because of what is deemed typical strength and endurance training. So the idea of training with weights and bands and treadmill walking and bike riding, there is plenty of evidence to support that this is helpful in regard to physical health and brain health or brain function. But someone with PSP shouldn't necessarily be doing 3 sets of 10 of a banded pull. Someone with PSP or CBD, if they're struggling to get out of a chair, that's a maximum effort movement. They need to train at a maximum intensity, moving heavy loads relative to the person. And a heavy load might just be their body in a different direction. But we need to be pushing them toward heavy, challenging resistance training. So I propose that as a profession, we are, and I'm first to throw our hand up, guilty of underdosing. So that intensity drives brain change and drives physical gains. So why are we as skilled providers not more likely to prescribe deadlifts, rows, lunges, physically challenging exercises that we know are functional in nature? They're challenging with patients who cannot do them independently, but that's the point, to push them to a new level. So I hope to see this more regularly accepted within the profession when pushing these patients. But at this time, there are no guidelines. So the research for strength and endurance training is fairly vague. But they can be useful. The problem is, what if a patient cannot do them? And I think specific to the questions that were posed prior to this webinar going live, it seems like many people tuning in right now are living with loved ones or living with a condition and they cannot exercise independently at that intensity. That's where this idea of forced exercise comes in. And that sounds kind of violent that it's forced. We should refer to it perhaps as assisted or augmented exercise. The idea that we use an external source like a motor on a bike or like a therapist's hands on a leg to help someone exert themselves longer and at higher intensities than they can do on their own. So there's significant evidence, for example, supporting forced exercise cycling in Parkinson's disease, using a tandem bike or a motor-assisted cycle, that it improved motor symptoms and neural activation on imaging. But no one has done this yet with someone with PSP, CBD, MSA, etc. It's not necessarily going to work the same as it did in someone with Parkinson's because these diagnoses are so different, but it sure is worth a shot for someone who can't sit and pedal on a bike themselves, maybe for an attention issue. They can't sit there and pedal endlessly, but if the motor helps them a little bit here and there, it keeps them engaged. And ultimately, that's what's driving the brain change, that they're engaged and attempting to move with the bike. There are some other means of achieving this too, through body weight supported treadmill training or robotic assisted gait training. Now, this is if you're fortunate enough to live near a major health system that has some fancy toys, to say the least. And these are not inexpensive devices and systems, but if you have a harness system available that can help unload the weight as you're walking, it doesn't make you feel like you're walking on the moon, but it does make it easier for you to step because you don't have to support as much of your weight. Excuse me. So that allows for increased walking speed, increased walking duration, and then your physical therapist can actually provide manual assistance to step with you to help move the leg the way we kind of want to teach it to move. And we know that that can work in other diagnoses, this idea of locomotor training. So let's do it with these patients. Let's give these folks that ability to feel what it should feel like to walk with normal step length and normal foot clearance. Practice it over and over and over, and then see can they retain it over time. Another means of achieving this would be through robotic assisted gait training. So using an actual robot, a wearable exoskeleton to help patients move who otherwise would not be able to. So a low-tech example similar to this would be using a standing frame to help someone stand and experience the benefit of weight bearing on a regular basis. But this robotic assist training takes it a step further. And there is some evidence using a treadmill-based system that it improved balance and walking for people with PSP. But I'm going to introduce you to one of my favorite patients here. We're going to refer to her as AC. She was originally diagnosed with PSP, and it's now updated for her movement disorders trained neurologist as CBD. So how am I using this training style with her? Well, she's been working with myself and a coworker, a former student of mine who's now a peer, pretty consistently for 4 years, barring some medical episodes along the way. She walks only in therapy, does not walk regularly at home. Many of the falls have occurred when attempting to walk at home. So at this point, we would say she's a therapeutic walker. It's just not safe to do at home, even with skilled aids there. So we're currently using an overground, so not a treadmill, it lets you interact with the environment, a robotic exoskeleton device to help her balance and walking. So what we've seen since starting this in recent months, it actually improved her speaking volume or her speech, maybe from training her lungs and exerting her during walking, but specific to this intervention, her ability to walk a distance in 6 minutes time, or the 6-minute walk test, increased almost 5 times within 2 months. So I saw her after a fairly major medical setback, and in 6 minutes, I believe we walked about 60 feet. And she just recently reassessed with my coworker and achieved over 300 feet. Now, this is not walking at home. This is only walking here in the therapy setting. So we have to suggest that there is some evidence that these exercises are great when you're here, but they also carry over. They induce change that is lasting. So I'm going to display some videos here to show you how Miss AC looks walking without the device currently. So here my coworker, Dr. Hayden Smith, is providing a handheld assist, and you can see the gait is rather slow. You can imagine that this could put her at risk for falls, as she has experienced. Now this is a video, and forgive me, we took this early on and have made several adjustments since, but just providing her with the walker support. If you look at the speed that her limbs are advancing, she's moving this physically independently. Hayden's there spotting to be prepared in case of fall, but this allows for Miss AC to take those steps and move at a much faster pace. And I just included this morning. Another patient of mine, who we'll refer to as SJ, she's diagnosed with multiple systems atrophy and sees one of the movement disorders neurologists here at VCU, Dr. Mark Barron, who's one of the main collaborators on these exoskeleton projects with me. Well, Miss SJ came to me specifically in the hopes of being a suitable candidate for this exoskeleton device. She does not walk at home. So I have only seen her 5 times in the last month and a half. We've had a couple ice storms here in Richmond. There were some scheduling issues because it's hard to get in at certain times and days of the week. But just in 5 sessions, the effect has been tremendous. So I'm going to talk through while I play these videos. So this is from our 2nd session together in January. So she was unable to control a walker at that time. So I provided her with forearm assistance that she could lean on me. And you see a fairly stooped posture, very small steps, slow to initiate. We walk with the device on with some assistance at first. And you can see we're figuring it out as we go here, that there are some quick movements and trying to make the device work best to help her move. It does not move her by itself. Well, here's what she looked like same day as soon as we took that device off of her. She's more upright, I'm more upright, her steps are longer. So in that 45 minutes, it had some immediate impact. But here's where it gets really interesting. By pushing her at this higher intensity, just in 5 sessions, her 6-minute walk test, she went about 8 feet on session 1 with the handheld assist due to some freezing. This morning, she walked 103 feet and completed 4 turns, independently managing this U-step rolling walker. Now I'm there providing supervision because we weren't sure what was going to happen. The look on her face after we did it was great. I said, "Were you surprised?" And she just kind of shrugged like, "I didn't think I could do that." My hope is that by continuing to push her at a higher intensity and use devices like this to do exercises that would be otherwise unsafe or impossible to replicate, that we're going to continue to see these gains and they will be maintained to get her walking at home. That's not to say this is the case with everybody, but using this external source like a motor on an exercise bike or a robotic assist or a therapist who knows how to use their hands to help somebody move better is going to help people move better than they could do on their own. And you don't need fancy equipment. So anything that produces an automatic response can be beneficial. It might be hard to follow instructions, but some of these reflexes are so deeply implanted in our neural network. If we start to fall, we're going to hopefully generate a stepping reflex. Now, the caveat, that can be impaired in these diagnoses, but utilizing that appropriately maybe helps train quick movements, or putting someone on their hands and knees, kind of teaching them to crawl as we would a child, will strengthen their core and their thighs or their shoulders better than telling them to lift a weight a certain number of times. Or one of my personal favorites, using a trampoline to perturbate or kind of shake someone up and make them adjust their weight shifting and their balance so that they don't fall over. So stepping onto a trampoline, jumping on a trampoline with assistance, of course, for safety, can be really useful in training postural reflexes. So moving forward, as I wrap up my prepared slides here, you need to find a skilled therapist to work with you if diagnosed with these conditions. And I'd recommend first and foremost starting with our CurePSP Centers of Care network. Also looking for Parkinson's Foundation Centers of Excellence. And specific to physical therapy, you can find therapists who are trained and board certified clinical specialists, either in neurologic or geriatric physical therapy, through the American Board of Physical Therapy Specialties. And I've included the link there, but please feel free to message me with any questions. Now, it is a balancing act, and I live in this dual role where I both want to serve the patient, but I also need to respect the scope of my practice as a physical therapist. And sometimes that line gets a bit blurred, but we have to make sure that everybody is acting most appropriately. And what I mean by that is understanding the patient and family's perspective, when it comes to managing the diagnosis. So the physical, emotional, and possibly financial burden associated with care. One thing that often comes up is, my loved one won't do the exercises at home, but they do it when they come here. Well, maybe the therapist is recommending that you hire an aide or someone to come in and do the exercises because they are not necessarily challenging to do by an untrained professional. But financially, that's a burden. So we need to find a way to work around that. Or is there support available to help in those cases? We want to understand that research is moving toward a cure, but people want something to help now. And that's where we can try new things as long as it's safe and within our scope, such as just displayed with the walking exoskeleton. There is no research necessarily supporting that device with those patients, but I know it's safe and I know that we're monitoring to try something new, and both of them were very excited at that opportunity. And then we also, as professionals, need to understand that burnout happens by both the patient and family, and that's okay. There are times where going to therapy might seem daunting or might just seem like it's droning on and on and on, and maybe the patient isn't engaged. It's okay to take a break sometimes, to kind of distance yourself, collect your thoughts, and give yourself that mental and physical break, and then come back into it. On the flip side, we have to understand the provider. So depending on the health system in which they work, there might be productivity standards or expectations that it's hard to, let's say, keep someone with PSP on the caseload who tends to cancel frequently. What if they're canceling due to medical emergency, or they're having a really bad day or a hard time getting out of bed? These are things that happen, but some organizations might not be as understanding. And then the really challenging piece, we must be able to ethically document a need for skilled care. Now, personally, I don't find that challenging because, we know what we're doing is helpful. We measure it, we test and retest. But that idea that Medicare only pays for improvement, that's false. You just need to document why you're providing skilled care. Keep in mind, if an individual with less training and skill can perform the same exercises as are done in therapy, it's difficult for a therapist to say that that justifies continued medical care. For example, if someone can walk independently but with close supervision, physically independent but close supervision, it's hard to say that they need my skill set when maybe a kinesiologist or an exercise trainer could help them as well. The third bullet point, keep in mind not every provider is as passionate about these conditions and their needs. So not everybody, has it in them to treat patients with Parkinsonism and PSP and CBD and MSA. For me personally, I respect that decision by any other provider, but I hope that you can find a therapist who is motivated to work with these conditions, or find a therapist who is open to input from other therapists who are passionate to help maybe guide your care. And then also understand that as burnout happens in patients and family members, sometimes it happens with your provider. If we're providing skilled maintenance care, let's say once or twice a week for months at a time, maybe it's a bit strenuous on us sometimes if we're doing the same things over and over that are beneficial, but they do become repetitive on our end. And sometimes that's where it helps to, reach out to a peer and mix things up. Miss AC, this is not due to burnout with her. I love working with her, but it has worked out really well for her to work with my coworker for a number of months. So now if I were to go in and see her and pick her care up as her primary provider, it's almost like seeing a new patient again because it's been so long since we worked together. So just understand that the stresses you're feeling are also felt by the provider, and everybody's fighting their own fight, but ultimately we want to get you paired up with someone who understands these conditions and provides you top clinical care. So please feel free to reach out with any questions, comments, concerns, or chances for me to collaborate a plan of care with your local provider. My email is listed here. But aside from that, I'd like to thank everybody for chiming in and listening to me go on about physical therapy for 45 minutes or so. And at this time, I'll take some questions.
Thank you so much, Bobby. What a presentation. Really inspiring to hear some of the experiences of your patients that you've been working with. And I think the perspective that you're sharing from your professional point of view is one that is really valued, not only by staff members at CurePSP, but also our community. So thank you. Thanks for being here today. We received some really fantastic questions about in preparation of this webinar. So I'm going to go ahead and lob some over to you. We've got a few more minutes left in today's webinar. So not sure if we're going to get through many. We received about 60 questions, so we're not going to be able to handle nearly that many, but I'm going to start by asking this one. Is there a physical therapy test that is repeatable and can be used to determine what level a patient is at in the spectrum of PSP?
Sure, I think that's a great question, Joanna, because there are not recommended tests and measures specific to PSP. Mm-hmm. So oftentimes we'll use balance and walking tests that are established in Parkinson's disease and Alzheimer's disease, and maybe use similar numbers because that's the closest thing we have to PSP. But we will measure someone's walking capacity through the 6-minute walk test, gait speed, and then oftentimes we'll do measures of balance to assess someone's fall risk. So one of my favorites for this patient population is called the Mini Balance Evaluation Systems Test. It's a mouthful, but it's a really useful test.
Great, good to know. Next would be a therapeutic, what kind of therapeutic approaches can be used to help with shuffling gait? And I know that you did talk a little bit about the use of the motorized tools that you have at your physical therapy practice, but is there anything else that you can share with our audience about therapeutic approaches for shuffling gait?
Sure, I could talk about that for maybe 2 hours as I do with the physical therapy students. So when it comes to shuffling gait, some of the best means of correcting that from a step length perspective are what we call visual cues. So maybe laying strips of tape on the floor or objects which the patient has to step over. Practicing that over and over might help break them out of a shuffle. Another thing we could use are what's called auditory or hearing cues. So playing music or a metronome to help kind of regulate a step so that we don't get stuck and start shuffling at some point. So I think they're both appropriate strategies to try.
Absolutely. Let's see. Are there exercises that you could recommend to help with rigidity?
Yeah, there were a few people that asked questions regarding stiffness and rigidity. And I think this is really interesting because we know that progressive resistance exercise training, or what we call strength training, can help manage that stiffness or rigidity. So those muscles have less blood flow than muscles that are not rigid. So by strength training and kind of pumping up that muscle, getting blood flowing in and out, we can actually reduce rigidity. And that's been fairly well documented, even in something as simple as riding an arm bike for a few times a week, reduced upper extremity stiffness and rigidity in patients with Parkinson's. So I think it's a good point to throw out there that just exercising and challenging yourself is going to help manage that in some means. I can't say how effectively without evaluating the person though.
Blood flow equals less rigidity.
And we have a couple of projects ongoing now to specifically address that, but I will leave it at that until there's more to share.
Fantastic. Let's see. Would you recommend continuing to attend physical therapy outside of the home? It's a very apt question for these times. I know in my experience interacting with patients and families over the last year, a lot of people have had to cut off going to see their physical therapists in office, and some are lucky enough to have people visiting at home. But what's your personal recommendation and take on the situation that we're in currently?
Sure. Speaking personally with the patients that I've built a great rapport with over the years, we've had this discussion that there are recommendations in place that people who are high risk should not be leaving the home. But on the flip side, if the only means of getting up and getting mobile is to come to therapy and work with a therapist, it's kind of a personal decision. Do you feel like it's worth risking staying at home, or is it worth risking going out and exercising, which you know is beneficial. So what I would say to everybody, and that's a serious conversation to have between you and your loved one. But if you're considering it and you recognize that, hey, I haven't been moving or exercising and I'm struggling, I'm not moving well, I'm not speaking well, I'm getting choked up, find a clinic that is being very proactive about managing social distancing and recommended precautions. I'm in a private treatment room right now, but out in my clinic space, we are all masked and wearing face shields and sterilizing regularly to minimize risk of exposure. So I would say if you can find a clinic like that, if it were me personally, I would choose to continue going. But again, that's for each individual.
Sure, it's a personal decision, absolutely. We've got time for one more question, and you and I talked a little bit off camera about this. Any recommendations for specific exercise programs for PSP or related diseases?
Sure. A couple people asked, and I don't want to butcher the different names of the programs, but I saw one about delay the disease. And then personally, some of the certifications that I have with LSVT BIG or Parkinson wellness recovery, there are these great programs and trainings and certifications that can help make you a better provider to help people with these conditions. But I would not get in the habit of following one program without considering other things. You want to be multifaceted. You want to be constantly changing it up. If it's boring to you, it's probably boring to us. We got to mix things up every now and then. So think of them at that terrible cliche, tools in a toolbox. Expose yourself to as many new and challenging things as possible as both the person living with the condition and the provider. And ultimately, you're going to see better gains than if you get stuck in a rut and keep doing the same thing over and over. So those programs are great, but make sure you're always staying on your toes.
Staying on your toes, getting specialized treatment and programs, and mixing it up. Fantastic. Well, thank you so much again for your time here today. This webinar was recorded and will live on our YouTube channel. So please, everyone watching, go back. I know Dr. Han covered a lot of really fantastic information here today, so I hope that you all take the time to digest it and process it and implement it into your own lives. So I also want to make mention of the fact that our upcoming family conference, which is going to be held virtually on May 21st and 22nd, 2021, is going to be held in partnership with VCU and with Bobby Hand and his team of interdisciplinary professionals there. So make sure to register for that CurePSP Family Conference. Again, it's 2 days, May 21st and 22nd, held as a partnership between VCU and CurePSP. So thanks again for sharing some inspiring stories from your practice, the crucial benefits of physical therapy, and expert insight into what therapy techniques are important to be aware of. We are thankful to all of you for joining us here today. We've had the pleasure of hosting some of the sharpest and most cutting-edge neurologists and interdisciplinary professionals in this important field throughout the year. So please go to our YouTube channel if you would like to view previous sessions from medical professionals like Dr. Golby, Dr. Panteliat, Dr. Scholes, and more. And we also have a ton of educational content for you to take in. And lastly, these webinars and events are only available because of donations from viewers like you. So thank you so much to all who have generously donated to our organization, and to people like you, Dr. Hand, for your participation on CurePSP Board and as a professional in this field. So we'll see you all soon. Thank you so much again, and take care, everybody. Be safe.
Thanks, everyone.